So again, I'm Josh Rubin, speaking about the learning health community. These are some disclosures. These are some of the roles I play. My main role is I'm executive director of the Joseph H. Cantor Family Foundation, and I'm program officer for Learning Health System Initiatives at the University of Michigan Medical School, Department of Learning Health Sciences. And I serve in some other roles in a pro bono capacity, including as now officially the president and CEO of this emerging group called the Learning Health Community that we're building. I'm also on the HIMSS Interoperability Committee, and I'm also involved in the Health Story Project. For those of you who are going to be here at, can still be here I think at 11:30, there's a Health Story Project presentation. It's really interesting. I'll encourage everyone to stick around for it. I have this disclaimer that what I'm going to say here is really my own views. When I talk about the community, it will be about the community, but there are other parts of this presentation where it's really just my own views, and please, when I say something stupid, don't credit it to Michigan or community or Canada. It's my own stupidity. I'm here on my own dime and own time for that reason. Bottom line is I've been working in this learning health system space for quite a long time, and we got my co-presenter is here, so I'll speed up my part and get through. I've been working in this space for quite a long time. I was asked recently in my role at the Cantor Foundation to think about what we could do about the opioid crisis, and I tried to learn everything I could. There's way more than any one person can learn about it, but digging into the opioid crisis, my goodness, are the statistics depressing? Is the way it got to be the way it is depressing? And we come to HIMSS and we talk about data, we talk about sharing, and we talk about all this stuff. If what we do here does not result in us being able to detect the next thing like this and the process that led to it, and we don't fix the process and fix the infrastructure and fix the things that made something this horrible possible, we're going in a wrong direction, and we have to correct course. And that's my sort of influence a lot of my thinking on this. Slides. So I'm going to be, in about 15 minutes, I'll be introducing Oscar Aline, who's going to talk about building a bridge, a major public health infrastructure that's actually going to address a piece of that kind of work, and he will get to that. And that's a little bit about the bridge. I'm wearing my learning health community hat. I think I want to start by how do we make healthcare more just, more equitable, more fair? How do we democratize health? And I will argue that democratizing health is the moral imperative of our time, because if we don't go in that direction, we're going to have more rising costs, more really bad things like the opioid crisis. I think there's this interesting spirit at HIMSS this year, and you're seeing just much more. One, interoperability is looming as so much larger even than in past years. It's always been a big deal here. It's really big. Second, I mean, we've had presentations where pretty much the former CEO of Google, the top advisor to the President of the United States, the CMS administrator, one of the biggest privacy advocates in the world, and some of the biggest patient activists, and so many others are now actually agreeing on where things have to go, and this much more patient empowering, put patient at the center, patient has control over their data, patient can do things with it direction, and we're really moving there. And I think we're starting a revolution. You combine that with some of the analytics things that are going on, and we're really moving forward. In addition, some of the news leading up to this, Apple getting involved. On this very stage 2 nights ago, Apple was presenting, and this Amazon Berkshire. There's so many more getting involved in this idea and can really save lives. I'm going to argue a big point is that the sharing at scale can save lives. I've often talked about the use case of this, about empowering an individual patient to make a better decision based on experiences of patients like them, sort of the precision medicine use case. That's the Joe Cantor use case, what he envisioned. Here's another big point of what we're doing. This guy, Larry Norton at Sloan Kettering, did this study about Vioxx, that it took us over 5 years to figure out Vioxx was killing people. And he showed that if we'd had, this is a slide from a presentation he gave at ECRI a few years ago, if we'd had 7 to 8 million people wired together, we could have figured it out in half the time. If we'd had 150 million people wired together, it would have taken us 6 months. And if we figured out how to wire the whole country together, we would have picked up on the safety signal in 8 to 10 weeks. Imagine if we could have picked up on the opioid epidemic in 8 to 10 weeks. I'm actually going to begin by telling a story of a father who had trouble getting his data to help his son who had brain cancer. I'm going to fast forward and let you know the moral of that story was going to be that the father was Joe Biden when he was vice president of the United States. We've had Seema Verna, the administrator of CMS, who technically, as Jared Kushner said, introducing her, she's the largest customer in the world for healthcare. She spends $1 trillion on healthcare through CMS. And she had a story about how she couldn't get her husband's data, her husband who was a physician. And Kushner also told the story during his speech about not being able to get data for his friend's mother, and that led to some errors or something. So there's this entire pattern of really, really powerful people can't get their data. Really wealthy people can't get their data. Imagine what this says about you and me. And so that's a key element. I'm going to skip through the information block and skip through some of this stuff. The heart of the matter is you can't get data from your implanted defibrillator. This is a great U of M study about why interoperability is not working, why data sharing, some of the barriers that, there's been a lot of optimism here, but there's still some major barriers we've been through. At the end of the day, we need this data. We need this data to flow through. We need democratizing to deliver on the promise of a health system where a human, plus all the technology that we have, plus all the information, can do things a human can't do alone. This is my boss at Michigan, Chuck Friedman's fundamental theorem of informatics. And one example is if you've heard of this guy that got hired by Apple not too long ago, but this MIT graduate student who built this, used all his data, built a 3D model of his own brain. We can make great things like this happen for everybody. But we really have to liberate the data, have to have it flow, have to change the culture, have to change the infrastructure. Bottom line is, because it's not happening, we have $250 billion going to criminals in healthcare. We have about almost $1 trillion being wasted, 1 out of every $3. We have a record number of medical mistakes, over 1,000 a day, and the U.S. ranks last among high-income nations on preventable deaths, even though we're spending the most. And that's just some of what's not working. I think at the core of a lot of this is that we're doing great research. We're doing some of the best research in the world in this country. It's taking 17 years for that research to get anywhere where it actually can make a difference. We need to speed up that pace too. And at the core of that's empowerment. E-patient Dave, who's been around here, you'll see him wearing his jacket, he's been around a lot. He took a World Bank definition of empowerment, increasing the capacity of individuals to make choices, transform those choices into desired actions and outcomes. How do we get to that? How do we make people be able to do that in healthcare? I think one is at the core, but we have to recognize that everything we learn from data is coming from a real patient's experience, coming from money that's either pooled from taxpayers, pooled from insurance companies, so pooled together. There's a public element to this in this culture that has to benefit everyone. It can't just benefit those. I'm going to skip over that example of disempowerment. Basically, again, I said the opioid epidemic, just trying to understand how it came to be. And the further you dig, the worse it gets. And I believe there's a lot of good people who meant to do the right thing, but I think there's missing information flows, missing structures, and bad incentive systems that led to a lot of the problems. But it's now a national emergency. It's the equivalent of a September 11th every 3 weeks in terms of people dying. It's the leading cause of death among Americans under 50, and it keeps rising. And if you dig in, the DEA was increasing things at this kind of rate too, but we just can't afford it. It's costing $500 billion a year, and it is making some folks a lot of money, but nowhere near $500 billion. So it's net negative society. It's leaving a future generation in peril. And again, all this was caused because we didn't have the data early on to show this stuff was absolutely addictive, and we knew it was addictive, but it didn't flow in the right direction. So we need to really be working on that. I'm just going to skip over quite a number of studies of things that didn't go, of things that could have shown this wasn't working that we weren't critical enough of. I'm going to skip through this stuff and really get to there's all kinds of problems with influence, and that's why information isn't flowing right. But I'm going to skip through this, not investing enough in R&D, and really get to these are some of the problems we have to solve. I think a learning health system doesn't address all of the problems that led to this kind of cause, but it really, if we can get to radical transparency, radical information flowing, put power in everyone's hands to set up an alert, hey, can you tell me if the prescription of some kind of drug is doubling, tripling, or increasing 39-fold in 20 years? If we can detect this stuff quicker, we can get to this solutions to this. So the solution is democratizing health, and I believe that's at the core of the moral imperative of the system. I think a way to do that across our country is this idea of a learning health system. At a national scale, it starts to look something like this. It's every kind of stakeholder is able to contribute data and put something into it, and every kind of data stakeholder gets something back, and there's some infrastructure that includes people, process, technology, and policy that everyone can trust to make it happen. I think there's really 4 ideas at the core of it, and most of these books, some of them are from the 1990s. None of them are like in the past few years. They're all a little older than that. So these are all ideas that have been around, been proven in other industries that we're bringing to healthcare. It's the idea of lots of analytical power, which we have. It's called a culture of sharing and mass collaboration, of everyone contributing, everyone doing something. This cultural commitment to learning and improving as a result of every experience. And this chaotic idea that was at the heart of this Visa credit card network, a mix of chaos and order. So one definition of a learning health system from the National Academy of Medicine is a system in which progress in science, informatics, and care culture align to generate new knowledge as an ongoing product of care experience. And they've a number of studies on it. I think more simply, again, it comes down to a cultural commitment. Are we going to share experiences, learn from them, and improve as a result of each one of them? Some of the characteristics we defined are every participating person's characteristics and experiences are available to be learned from. Best practice knowledge does not sit in journals for 17 years, but it gets put out there where people can learn from it in forms they can use in the right form at the right time for the right reason in a usable way. There's constant improvement. It doesn't stop. There's ongoing. The walls between research and public health and clinical care are broken down. And there's really an infrastructure that enables this. And this infrastructure, I think, will address a lot of these crises. It's a new culture. In the next few years, by 2020, there's going to be 50 times as much data to draw from as there was in 2015. We're at the halfway point of this. This is David Brailer, one of the founders of the Karen Alliance, first national coordinator, who speaks about this. I find this startling. To estimate the doubling time of medical knowledge was 50 years in 1950. It may be as little as 73 days by 2020. So keeping up with stuff is going to change. This is not go to medical school, learn it, read a few journal articles. You couldn't read enough journal articles to keep up. This is Watson or things like it are going to be helping, but we need a lot of help. It's really about this infrastructure is about thinking through these different kinds of cycles of continuous learning and improvement. The cycles take the form of really three parts of capturing what happened, which is performance to data, taking what happens in the doctor's office, what happens in the real world. It's analyzing the data and turning it into new knowledge, and then which is data to knowledge, and then taking this new knowledge and figuring out how to get it into practice. And we got to do all three of these things well, and we can get some help from artificial intelligence. There was a whole AI day and machine learning day on Monday here. We can get some help from that, but it's about mixing people and technology to do these better, and we got to do a better job of it. So there are examples of these kind of systems coming into place. There's PCORI has funded about 20 different clinical research networks or 20 different patient-powered research networks and 13 different clinical networks. There's CancerLink. There's major efforts happening internationally. There's the Transform effort across the whole EU. There's actually a Swiss-branded learning health system initiative. Some of the slides I showed you have been translated into Swiss, which is sort of amazing. There's stuff in Taiwan and Japan. There's there's some of the best examples that are presenting here. Kaiser's, Geisinger's, and the Department of Veterans Affairs has been on this stage. And then thinking through what this looks like at scale, in about 2012, so going on 6 years ago, we brought together about 80 or so chief information officer types at some major vendors, leaders of patient advocacy groups, leaders of pharma, other IT thinkers, other strategic thinkers, and said, what is this thing going to look like? And came up with about a 2-page long document that's really sort of like the constitution of this vision. So it's the core values, and there are 10 of them. It's person-focused. I'm just trying to keep an eye on time, get ready for my co-presenter. It's person-focused. It respects privacy. It's inclusive. It's transparent, accessible. It's adaptable, which we've proven we have to be, and so on. There are, today actually there's 118 endorsements of these. The University of Pittsburgh Medical Center's Department of Biomedical Informatics has endorsed since I submitted our slide deck. These are companies that compete vigorously with one another, including companies that are in the Interoperability Showcase, Epic, Cerner, for example, Eli Lilly, Glaxo, for example, and others that compete, groups that may not trust each other, lots of academics, lots of countries around the world. There's an organization from India on here. There's an organization from the UK, the EU. And there's, it's really built this community that when you hear about a learning health system, we're now one of the first things, or sometimes the first thing that comes up on Google. And HIMSS has been a huge proponent of this, supporting the core values. What else can I say? HIMSS has helped make introductions for us to great people to help. We've organized these working groups that have been really trying to work together to work on pieces of the puzzle. So organizations that believe in these core values have sent people on their own time, totally voluntary, donated space to really work on producing communications, producing a governance infrastructure, thinking through what the key standards would be, building on things that exist in CDISC and HL7, and trying to move this forward. Some of our work products. Most interesting, in the federal health IT plan called the Shared International Interoperability Roadmap, quotes the vision statement and really says this is where our country has to be by 2024. And you've seen reinforcement from that now. We saw a lot of it during the Obama administration, and I'll say the kinds of things that we've seen on stage here at HIMSS from the Trump administration have also reinforced this kind of commitment. even more so to putting the patient at the center of it. Again, I've mentioned that we've been going global in this space, Swiss-branded initiatives, Taiwan, Japan working on this, lots of work happening in the EU, and all over America, of course, as well. Building on this, we took a bunch of people that had demonstrated their commitment to working in this space and brought them together a little over a year ago to start visioning what would an action plan to A, accelerate progress of learning health systems, and B, make sure they all fit together into something bigger than the sum of the parts, because we need this kind of national exchange to get to solving big things like the opioid crisis, addressing rare diseases and things that no system can do alone. So we put together this action plan. We have, again, leading patient advocates, people that had really demonstrated commitments, organizations building LHSs nationally, internationally, folks flew over from Europe on their own dime to do this, and had major support from these kind of organizations, especially the Cantor Foundation was a big supporter, but you see HIMSS and others have been supporting this, and really worked through and had people really think through what their organization could do. I have a few examples, including at the time the National Coordinator for Health IT was involved, and I just put a few of the slides. I have 100 some out of these, but folks at HIMSS made slides too. Crystal Anderson, many of you met. Valerie Rogers is amazing. So these are two folks from HIMSS that really contributed a lot to this effort. And came up with this action plan that really falls into 6 buckets: promoting and disseminating the vision and the value it'll bring, making the value case, the business case, defining components, assembling them, cultivating the culture that will drive adoption, engaging all stakeholders, probably especially consumers, formalizing best practices, and funding and sustaining the movement. We've worked to publish this action plan. We put it together. It's out there, and we're turning the learning health community that's been sort of a grassroots movement and a website and a meeting of people into the formal nonprofit that was envisioned at the very last step of the plan. So that's where we're going. These are some of the folks working on it. And finally, I started at the beginning by talking about Apple getting involved, other companies getting involved. If you're following the sort of health finance in this space, there's been a lot of mergers this year, a lot of deals. There's deals happening here. I think that's important, and we're bringing powerful entities, and we're bringing major brain power and major money to some of this stuff, and that's really good. I do think we should always keep an eye on, are we ever approaching a phase with more consolidation, or there are problems with that too, and how do we think that through, and how do we balance it? Is there any risk of too big to fail, too big to jail, maybe too big to heal in any of this? We should need to balance all this. And that's why I'm ending with some of the thinking. I think that in the internet there's been a lot of thinking about this. So I ended with the paper about net neutrality. Oh, by the way, I'm surrounded with Reese's peanut butter cups because, one, I'm going to give this to you guys as snacks afterwards, but two, if you don't know what Reese's peanut butter cups have to do with thinking about net neutrality, Google it, and you'll find decisions about net neutrality were made by, I'm seeing if some of you know what I'm talking about, but some decisions about net neutrality were made surrounded by Reese's peanut butter cup mugs, and I'll leave it at that. So anyway, the guys who thought about net neutrality have looked at this cycle of things starting out very, very scattered and chaotic, and then consolidating, and how do we think through this future of health? So I think at the core, there's a question posed by Joe Cantor on what coincidentally was the 50th anniversary of the Martin Luther King quote I started with about injustice in health, that we've moved this idea from impossible to imperative to inevitable. What we now need to do is fight for the soul of this future, make it one that is equitable, helps everybody, that empowers patients, puts powers in the hands of many, not few, democratizes, makes it more fun and better to be a doctor, more rewarding to be a doctor, a nurse, a clinician, a public health professional. They're not a cog in the machine obeying a screen in front of them. And it's our job to get her to bring that future. So next, I'm going to turn it over to Oscar, who's going to talk about a public health bridge that's going to make some of this happen. And I'll leave it at that. Oh, and I guess here you go. And the slide guys have to turn it over to your slides. Thank you. Good to see you, man. We're going to do questions after he and I both speak.
Good morning.
I'll make sure they get his slide deck up. And switch mics. You don't want to hear me.
One, two. Oh, good morning. How's everyone today? My name is Dr. Oscar Allen. I am a senior advisor of public health programs for the National Association of County and City Health Officials. The National Association of County and City Health Officials represent the 3,000 county and city health departments across the country. So for lack of a better word, you probably can figure out that I represent public health. Yeah. Today's presentation collaboration with what was just mentioned a few minutes ago, is to address and present some of the work that we've been doing in public health with our partners around Digital Bridge. And as we kind of called it, it's the transforming of Digital Bridge into our health landscape. What is the Digital Bridge? It's actually a partnership between healthcare, health IT, and public health to essentially provide a bi-directional flow of information through the information exchange that we have known to actually love within the most recent years. More specifically, the goal is for Digital Bridge to be an incubator for growing projects that can actually be from farm to table, more specifically, taking action and putting them into practice, more than just being theoretical. And it's also a forum for sharing of our ideas. Where else can you have the opportunity for public health, the vendor community, as well as the clinical groups to come together to say, enough the theories, we want to put some things into practice. It is funded by the Robert Wood Johnson Foundation and the De Beaumont Foundation, and has been, I would say, organized in some respect through programmatic management with Deloitte and Public Health Informatics Institute.
When he finishes, I'll go back on stage.
Your mic's still live, Josh. Now, I'm going to talk about the initial focus of what our Digital Bridge work has accomplished within the last year or so. But I first wanted to show you the partner organizations that have been part and parcel in making this practice come into action. We have Allscripts, we have CSDE, APHL, ASTO, Epic, Cerner. Many of the players that are here today and others have actually vested their interest to say, we want to try to make this work. We want to volunteer our time, our efforts, and our energies and resources to coming up with a solution that can work across this particular landscape. Now, with anything, you must have a governance structure. So Digital Bridge as itself, as an entity, does have a governance body, which is organized primarily by John Lumpkin under Robert Wood Johnson. As you notice, the three pillars are essentially similar to our pillars of healthcare, public health, and the vendor community. How else do we get to essentially represent those concerns and those solutions if we don't have all these individuals at the table? And as I illustrated prior, the program management side of the organization, plus the ex officio members, those federal entities, ONC, CDC, as well as Deloitte, who are vested partners in ensuring that we can at least accomplish some success in all ways, shape, and form. And as Joshua had mentioned before, with his particular work groups under the Learn and Care initiative, we also have had developed some work groups to address key areas of how can we make this Digital Bridge effort work? How can this initiative actually come forth in a way that makes sense, that addresses the legal frameworks, the technical standards, as well as the practice elements? Now, this is where I say I will go low tech. This is the old jelly bean slide that we tend to use in public health. Now, as I mentioned, I spent 16 years as the director of epidemiology at a local health department. As a virtue of being an epidemiologist, my role was to ensure that I tracked and traced all of the diseases that impacted the members of my communities. So in this jelly bean picture, we actually see central to the local administration of the public health is the public health agency. We're not saying we're above and beyond. We're just talking about that central coordinating, convening authority that public health agencies have, whether at the state or the local. But I'll talk to you from the local framework. So being a local epidemiologist, my interface was not only with the hospitals or the clinics that were provided by my health department, but also neighborhood organizations, the community health centers, elected officials, nursing homes, community centers, individual private providers, large-scale practices, whatever it may be. We had a linkage to all of these entities for the purposes of addressing health security as well as the provision of care and services throughout that extension of the system. But what does that mean? we are not omniscient. We're not going to know everything. And in particular, as it pertains to the tracking of diseases, we oftentimes needed to ensure that there is that extensive network of communication and provision of information in a way that was timely, complete, so that if there were growing emergencies, outbreaks, or just general care, that there was at least a understanding as to what was in the community and how we could rapidly address them in some way, shape, or form. And this is where the concept of the digital bridge is of great value, not only for public health, but for all of the entities that we mentioned within this partnership. You see, the digital bridge approach was primarily focused on electronic case reporting. Why was that even, like, well, what's the big deal? Everyone does EHR or ECR. In actuality, many of our public health authorities do not have access to electronic health records or electronic laboratory reporting systems. Now, mind you, what I mentioned before, if I am responsible for 60 to 70 diseases being tracked on a daily to weekly basis, and I'm receiving data through fax, through mail, I'm actually at a disadvantage for actually being able to address the needs of my community. So having access to electronic case records or electronic health records, or in particular electronic labs, really enhances the ability for not only the response, the mechanism for ensuring that we have things under control with respect to situational awareness, but also that communication back to the provider communities in a way that helps them also provide their clinical decision support mechanism. So the approach that Digital Bridge took with respect to ECR was to look at an interoperable, scalable, multi-jurisdictional approach to the electronic case reporting regime. We recognize it's not a new technology product, right? We know that many of these access points exist. We see them here with respect to the HIMSS, showcase, et cetera. But the approach was to identify what are those tools and standards that can be then employed to ensure that we have a much seamlessly, timely, and complete aspect to adoption within the three areas that I mentioned, those three pillars. So ECR was incorporated with the electronic health record as kind of a background operation, which would have zero, or I should say minimum impact on the actual clinical end user. How best can we then leverage the technologies that were mentioned before in that learning capacity to ensure that there's that seamless sharing of information that allows those decisions to be made without necessarily adding undue burden to the clinical provider? So this approach, we actually focused on looking through 7 implementation sites in 2017. And the idea around them was to have that technical solution where EHR is a vendor agnostic approach, meaning that any vendor in this landscape can adapt and hopefully look at these solutions in a way that can provide greater functionality to the clients that they serve. So, what are the benefits of this digital bridge approach? Simple. We have a unified process of information exchanging. Simple. It eases the burden and it allows for there to be reduction of cost to all stakeholders that are impacted. It lays the foundation for better bidirectionality exchange. One of the things that I can say that the public health and the clinical providers did say, bidirectionality is of great importance. There's one thing from a clinician to say, well, I've reported to the health department, but that's it, it's a black hole. Nothing has come back to me. I don't know what to do, or I don't know the outcome of my report. Likewise, public health recognizes that there's information that they have, and they can in turn provide back to the end users, so as we have that enhanced network, that duality approach that is not it's more symbiotic and not necessarily one of being parasitic. That's my analogy, forgive me. So we recognize that, especially as it pertains to that bidirectional data exchange, we can hopefully even extend further outside to those of the non-communicable disease exchange components. Now, with ECR, the whole premise, of course, is that automated generation and transmission of case reports through the electronic health record to public health agencies for there to do review and action. And as I mentioned how on a daily basis, epidemiologists, nurse practitioners, everyone else who are in the public health space have to respond to these types of ordinary activities, the concept around the ECR reporting structure is quite simple from our perspective. The provider enters information. whether or not it's patient records that they see in their particular practice. The health information technology actually sends that information seamlessly through necessary triggers that have been developed for standards and reportability. Then, within that framework, that decision mechanism, there's the determination of, is this a reportable disease or not? Are we in a process where this is something that needs to be reported based on the jurisdiction? And I give you a quick example. Some jurisdictions, chlamydia may be reportable, others it may not. So the matrix allows for that reportability determination to occur. And then there's the analysis and evaluation by the public health authority. Upon receipt of this data, now I am able to say, what do I now do with this information? Does it validate my EPI-case definition, or do I have significant issues that I can now either extend back to the provider or make a determination as to the status of this particular disease? And that's where we talk about then the bidirectionality, the provision of feedback to the provider community in a way that's seamless and that's helpful to both the public health as well as the providers. So the value of ECR, we can say, is pretty much extant. You have more complete, timely, and hopefully accurate data that allows you to be as close to real time as possible. It allows for early detection of cases, whether it then gives us the opportunity to provide early intervention techniques to stop the rise of, let's say, a hepatitis outbreak or diminish the true burden that we find of transmission of disease in the community. It's one thing, and I can always say, whereas public health tends to look at the larger picture, whereas clinicians tend to look at their practice population. And it's often interesting to see folks say, well, I treated this person for that. And I said, but you didn't contact the health department because we actually have 15 cases of this particular scenario. Oh, I didn't know. So how do we then allow for that diminished transmission to occur and improve the detection of outbreaks as well as our own state and local partner needs? So the implementation sites that we have, as I mentioned, there are 7 across the U.S., primarily California, Kansas, Massachusetts, Michigan, New York City, and Utah. And you can see who the healthcare providers were in those entities as well as their EHR vendors. Likewise, this is where essentially that GIS map of where our implementation sites were developed across state and local jurisdictions. And the participation actually was focused on 5 conditions initially: pertussis, gonorrhea, chlamydia, salmonella, and Zika. And the participating sites allowed for that evaluation of how well is this ECR mechanism developed in a way that makes sense and gives us correct information that hopefully we can then transition to others within the community. And I think we shall end here for our conversation. Josh, you're up.
Okay, great. Cool, we got it.
2 mics.
We got both mics on, yep. Welcome, everyone. Does anyone have any questions?
Question about the Learning Health System initiative. Are you guys facilitating pilot implementations or profiles on how to use standards, or is it more high level agenda setting?
The role of the community has been to convene the discussions and to bring people together. As we become our sort of own nonprofit, we're looking at a couple of different avenues. One is possibly really finding ways to measure learning health systemness of, let's say, of a Kaiser or someone who says they want to be one, and possibly to help them connect with experts who can help them become better at what they're doing. Wearing a different hat of mine at the University of Michigan, we do have some pilot projects at different levels of scale around this concept. We built some infrastructure we think will help around the problem I mentioned about the 17-year bench to bedside. We have some of what we call knowledge grid. It's our approach to knowledge curation, and we are testing that on different things at different levels of scale. So we're trying local projects within the U of M health system, turning the whole state into a learning health state, as well as national level and even international.
Thank you.
Question on the digital bridge.
Yes, sir.
Are you actually exchanging the personally identifiable information, or are you just reporting on the health incident itself?
It is personal identifiable information, mainly in public health law for the purposes of the national notifiable diseases. If there is a case of a notifiable disease, that public health information or that private health information can be transmitted to a public health agency. So that's where the process of addressing, how do we deal with legal frameworks, data exchanges in a way. But as a public health authority, I technically can go into a provider's practice and obtain the health records of an individual that has been reported to be ill based on that notifiable disease list.
And then how does the ECR compare to an HIE electronic health record? Could you help me understand?
So the question is, how does an ECR relate to an HIE electronic health record? I would say they're in and about roughly the same to some capacity. The HIE, that health record that's being exchanged, dependent on what is contained in that profile of the individual's records, may or may not tie into the ECR component in this following way. Let's say I have an individual that tested positive for hepatitis, and I get an electronic lab stating that individual is tested for hep. The access to the record can actually tell me, more importantly, is there any other factors that play? Was that person exposed to hepatitis previously? Are there titers that existed before that? So it allows me for a decision-making process to now say, well, this record tabs in, we are able to create our case report and complete our analysis in that framework.
That's another.
Hello. Yeah, I had one question again about the digital bridge and some of the implementation sites.
Oh, sorry.
It's hard to figure out where it's coming from.
Once you get a chance to review that case report and you need to communicate back to the doctor, is that happening through the EHR, or is it like an outside direct email message to that provider? I wonder how that works.
So the question is, how does the feedback go back to the provider? And that's one of the areas with respect to we've had great conversation around the clinical decision support system and what is the best mechanism to get that information back to the provider in a way that makes sense, that's effective. So in one capacity, there is the use of the electronic system to push messages back, as well as whatever mechanism to, maybe there's a opportunity to pull a flag in the EHR system itself to essentially report back out to the provider in a way that's it's unobtrusive, if I get my point. There's still a great conversation with respect to what those implementation sites will show us and will illustrate in the feedback as to what was the better modality for that direction back to the provider. But there are several being explored in that case.
Thank you.
Yep.
Questions? Your question?
Yes, sir.
Hi. I guess I just wanted to know why you think governance is so important, and what would happen, and I guess maybe if you were to explain a little bit more in depth the parallel you're trying to draw between net neutrality and a learning healthcare system. And it seems like the biggest impasse between all of this is the gap between research and adoption. So how does governance help that?
So I think, I think the key with governance is it's really about building a trust framework that gets people to want to do the right thing. And you need to have, you need to have faith that, if we're asking people to use certain standards in their data exchange, there has to be a faith, there's a governance structure that's going to look at that in the right way. I think there are, in general, standards or parallels to the internet. You need just the right amount of governance. And when we were planning this originally, we had David Blumenthal and Rob Kaladner. So we had an appointee from the Obama administration and an appointee from the Bush administration helping to think this through as national coordinators. And the idea was it really has to be a totally sort of a trusted, completely neutral organization to be at the center of the governance. That even the government itself can't and shouldn't be building the governance structure for this. Again, we also looked at a model from Dee Hock, who is the founder of the Visa Network, and again, also a very very light governance, but basically getting everyone to agree on a core set of values and a core vision for where it has to go. And because it's too complicated to get everyone to agree on everything, but you need the absolute core of it. And again, the trust framework. And I had that sort of map of the country with all the different kinds of entities. But there's something like a cloud where they're exchanging with each other and trusting each other. And I know Oscar gave a lot of thought to governance of.
Yeah, and if I can jump in, I know it was directed to him.
Yeah,
but using the digital bridge as an example, mentioned 3,000 counties and cities, 50 states. How many vendors are out there that have developed their own particular systems for their clients, for et cetera? How many physician practices are in play? So how do you get people to come together in a way to say, let's play nice? Everyone has their vested interests, their vested authorities, and while governance may not necessarily have to be a government official, the role of a convening authority to help shape and bring players to the table to ensure that this tall order that we had, I mean, Jim and a few others from program office would tell you, we had to ensure that we kept almost bi-weekly meetings, had several different work groups that were working towards these standards, that were at least hashing out what were some of the legal efforts or those frameworks. So governance is technically important in a wild, wild west scenario. Otherwise, everyone would pretty much say, I'll just take my, my toys and go home and just operate from that strictly insular framework.
What lessons did you learn from the failures of the HIE that you've taken forward in the digital bridge to see it be more successful?
I think the first lesson is having the vendor community at the table. And that was very seismic because the digital bridge, pretty much people have said, we are going to volunteer our time and effort to make this thing work. Whether or not it's governmental public health, the clinical provider communities, and the vendors themselves, it was important to have all these three pillars at the table. And they weren't done in an insular fashion. I would say those who watch the Lord of the Rings, you can't have the Tower of Mordor thinking that, yes, we build it and they will come. But how do you essentially bring those stakeholders in a truly organic manner, fashion, to say, we recognize the value you bring to the table. These are the standards. These are the opportunities that we're looking as a greater outcome. And we're going to have this leap of faith that we're going to try this, and hopefully you will find value in each of your particular pillars to say, this is a value to our organization, to our represented stakeholder community, and we are going to take this leap to move forward to at least attempt some solutions. And I think that in of itself, in comparison to the technical history that we've seen with HIEs, that was probably the biggest difference with respect to how Digital Bridge approached it. All right. Thank you.
Thank you. Yeah.